Okay, I think we should start now. It's already 10 o'clock. Okay, Dr. Sally.
Okay.
Assalamualaikum and very good morning, dearest colleagues and participants. Welcome to the first IAP weekend session for the year 2022. Similarly, in 2021, this year we will continue our regular monthly sessions with new lineup of topics and speakers. Today, it is my great pleasure to introduce my fraternity colleague here, Dr. Sellymiah Adznan, as the speaker for this month. Dr. Sally is currently the anatomic pathologist from Department of Pathology, Hospital Kuala Lumpur, graduated with MBBS from University of Malaya, and subsequently obtained her MPath from UKM in 2010, after which she was based in Hospital Serdang until 2018. She then pursued her subspecialty training in pediatric and perinatal pathology at the Children's Hospital at Westmead, Sydney, Australia. Placentas can be quite bothersome and taxing for pathologists, and eventually we can't run away from it. It has been a year since we had the first placental session, so this year, to refresh this topic from her perspective, Dr. Sally will highlight some important placental lesions, particularly that should not be missed in routine reporting. Before we start, kindly fill up the attendance form provided in this channel, and I would like to seek your cooperation to mute your microphone during speaker's presentation and keep your questions at the end. Or alternatively, you can just drop the questions in the message panel. So without further ado, please welcome Dr. Sally to deliver her talk. You may share your screen, Dr. Sally.
Okay, good morning. Assalamualaikum. Am I sharing the correct screen for the viewers, not the presenter?
Yes, this is the viewers.
Okay, the viewers. Okay, not presenter. Okay. Okay, Assalamualaikum again. Good morning. I'm going to present just the placental lesion, which is not to be missed. So basically, just to be very simple, I don't want to do much of the reporting, just more of identifying the pathology that need to be recognized by the pathologist. I'm aware that we are not not all the hospital practice sending all the placenta. So basically what I'm presenting probably the ideal practice in dealing with placental specimen. However, I will try to incorporate with our daily, what we used to practice in Malaysia. Hopefully we will change to a better practice. Yeah, submitting the whole placenta. Okay, I will start. This is the placenta, which is freshly from the mother. Okay, I'm sure you know that's the umbilical cord. I'll show the umbilical cord, and this is a very nice the fetal surface showing the vessels, and then of course the opposite side will be the maternal side, and you can see part of the membrane. So basically, during grossing, we need to assess the cord, the disc, which is the fetal and also the maternal part, inclusive the membrane as well. Okay. I will start with the gross findings of critical value. I'm sorry, this is the best that I can find the pictures. Okay, number one would be the placental abscesses. So this is the area of concern. I mean, interest is this yellowish area. You should be okay. Some certain what you call the infarction also will appear like this, but infarction will be more firmer, but in abscess it will be more softer. So basically, if let's say you see this, you must suspect Listeria infection or Listeria placentitis. Some other reported case they also mention some rare of Serratia marcensis. So this is among the I mean the placental abscess. So I will show you another picture. Sorry, so this is the area of interest. The background will be is already blurred. So again, this is on the maternal surface showing the abscess. Okay. Okay. On histology, it will be again abscess. Easily, you can you cannot miss abscess with necrosis. It occupies at the intervillar space, and in pushing the alveoli to the sides. Okay. Okay. The second lesion is the umbilical cord abscess. Usually it will be pinpoint. You should see very carefully. It can be numerous yellow, white plaques like this. This is very characteristic of Candida infection. This is another view, which is near to the cord insertion. You can see all these small dots of foci of white. This is Candida punya ni lah. Okay, this so under higher power, I mean under histology, usually will be at the periphery. We call it as peripheral phoenicitis. Then we can do whichever you choose, whether it's PAS or GMS. You can see the hyphae or yeast under the special stain. Okay, that would be the number 2. So number 3 is this diffuse chorioamnitic hemosiderosis. I personally haven't seen this as well. This usually the extraplacental membrane have muddy brown tan colored opaque. If let's say you have the placenta, full placenta with you, it is caused by chronic bleeding during pregnancy, causing the red blood cells and breakdown of their product, which is the hemosiderine. I mean, you got deposit into the amniotic fluid or in the subchorionic space. Okay, it's associated with chronic lung syndrome, pulmonary hypoplasia, pulmonary hypertension, and neurologic complication, which is in the chronic abruption oligohydramnios sequence. This chronic abruption oligohydramnios sequence is a clinical setting in which they have oligohydramnios without rupture of the membrane. So basically it's an intact, it's not leaking. The oligohydramnios is not because of leaking of liquor. So it's because a repeated episode of vaginal bleeding starting as early as 19 weeks with gradual progression to oligohydramnios. So because of this, because of the oligohydramnios, the baby will develop, because the liquor will help for the baby to develop this lung. So the what do you call the baby swallowing the liquor is actually help the baby to help the lungs to mature. So basically, because of the oligohydramnios, the baby will have this chronic lung syndrome and also pulmonary hypoplasia and pulmonary hypertension. So therefore, usually this kind, it depends on how severe is the pulmonary hypoplasia is. If let's say the baby delivered, the baby usually succumb. So basically, if let's say we have, we can see this, if we have this, we receive this specimen in a baby of, I mean, diffuse chronic hematopoiesis, 50% of them are because of this chronic abruption oligohydramnios sequence. Okay, so this is the gross picture. This is actually a quite fresh specimen. One might think it would be meconium stain placenta, because it's also like greenish, brownish in nature. If let's say we receive it as, if let's say it fixed, probably the only thing you can see probably opaque membrane under, I mean, microscopy. I mean, you can see hemosiderin laden macrophages, and to prove it is not meconium, we must do pearl stain. So when we see this, then we can suggest there's a chronic intrauterine bleeding causing deposit of hemosiderin in the membrane or in the epithelium as well. If let's, but for this case, it doesn't have. Okay. Okay. The other case is massive perivillous fibrin deposition, or the older name is maternal floor infarction. It has a high recurrent risk. We need to investigate. I mean, if let's say we need to investigate any renal disorder or metabolic disease in the infant, and also usually associated with maternal thrombophilia or autoimmune disease. Okay. Another picture. This is actually basically, you can see this is the maternal surface, this is the fetal surface. You can only see the fibrinoid necrosis at the maternal surface only. I mean the maternal area. On the other side, on the right-hand side, you can see here at the maternal side, this is transmural, I mean the whole thickness of the placenta. Here only the maternal surface as well. To diagnose maternal floor infarction, you need to have a full placenta. For me, you need to have a full placenta. This is actually from HKL side. Sorry for the what do you call, the kecomotan of the background. Okay, so this is basically, I just want to show you area that just have the fibrin deposition here. This again here, seen here, here as well. So basically, it's just firm 10 white lesion. Be aware, this lesion, if let's say sometimes you can see at the side, which is usually normally seen in term placenta, because of the fibrin get deposit further away from the, because this part is actually less supplied, not best supplied by this. So sometimes part of the villi are degenerated and surrounded by fibrin, usually at the sides. But pay attention, it should be at the maternal floor and also probably transmural. So for this, you can see it here, you can see it here as well. But this one could be questionable because really at the periphery probably is an infected site. Okay, all right. So the histology is pretty obvious. This is the decidua. This is the degenerated villi, which is surrounded by fibrin. Another power here, this is actually almost transmural, inclusive of this is thrombus as well here. Okay. Then it's characterized by markedly increased perivillous fibrin or fibrinoid deposition, either diffusely throughout the parenchyma or isolated to the maternal floor. This is rare. Fortunately, it's rare. less than 1% in all pregnancy, but we must be aware. So far in HKL, during 3 years in HKL, only find only one.
Mak
Okay.
ikan dekat kat luar ni makan. Banyak tu.
Okay. Dah makan ya?
Okay, proceed. Saya dah mute all lah.
Dr. Sally, please unmute your microphone. Dr. Sally?
Okay, can you hear me now? All right. Okay. So, okay, we'll start again. It's rare, less than 1% in all pregnancy. The recurrence risk is high, it's up to 78%, up to 80%. It can recur at early gestation. So as early as 20 or 19 weeks.
Your breakfast is so yummy. Aduh. Aish, jangan jalan.
Again, Dr. Sally, please unmute your microphone.
Okay. Can you hear me? Yeah. All right. So actually, there's no accepted guidelines for diagnosis histologically. Okay, some there are a few, so I just take a few that I'm quite comfortable using these criteria. So if let's say I want to say maternal floor infarction, there will be 3 mm of fibrinoid material entrapping villi along the maternal floor in at least one microscopic slide. So the massive perivenous fibrin deposition, I will require 50% of the villi on the slide encased by the fibrinoid material. Okay, some, however, must be supported by the grossing. 20% of the gross placental mass is affected. Means I need to slice the placental disc macam tadi tu, really slice and see how many percent have the placental being affected. So sama ada dia that 25% tu whether the MFI or either massive or both, so then I will have to diagnose. But the problem is when we have a fragmented tissue, usually in first trimester or early second trimester, because it's ERPOC, it will be fragmented. My criteria, any intervillous or perivillous fibrin deposition should, I will say, there's a possibility of MFI or MP, I mean, massive perivillous fibrin deposition. But if let's say this case is induced by protein, and because induction, I mean, a medically induced abortion, it will increase the fibrin around the villi. And also, it's not a case of prolonged retention of missed abortion. So prolonged retention missed abortion also will have a lot of perivillous fibrin deposition at the maternal floor. So if let's say there's two of these is not in those fragmented lesion, then maybe you can offer MFI or MP, I mean, maternal floor infarction or massive perivillous fibrin deposition. If let's say the history, I mean, if let's say the mother has history of maternal floor infarction or massive perivillous fibrin deposition before, so you actually can confidently offer the diagnosis of knee straight away because it's recur. It will recur and recur. So it will be recur. Tapi there's one report. There's a successful pregnancy after 4 recurrence of maternal floor, but the one with intervention. So basically, that's the case report said 4 maternal floor infarction. I mean, 4 fibrin maternal floor infarction or massive perivillous fibrin deposition. You can actually have a normal pregnancy, but with intervention. So that's why we need to inform to the the ONG part, that actually that this mother, the recurrent abortion is probably due to this condition. Okay, if let's say failed, probably the mother can opt for surrogacy lah. Okay. Okay, the other lesion that grossly can see is the placental mesenchymal dysplasia. Sometimes you can see it grossly, in which you can see under the chorionic, the fetal surface here, or the chorionic plate, you can see some of this cystic, what do you call, and also dilated, like grape-like structure within the placental parenchyma. So there are also some dilated vessels or an irregular arrangement on the fetal surface. Here, just want to show you the presence of dilated serpentinous vessels, which usually thrombose. So what we need to be aware, because it's a strong association with Beckwith-Wedman syndrome. So what is this Beckwith-Wedman syndrome? Is actually disorder of the child, in which sometimes the child has hemihyperplasia of the body. You can have the child can have abdominal wall defect at birth, sometimes has abdominally large tongue or abnormally large abdominal organs, and also strongly associated with Wilms tumor, rhabdomyosarcoma, and hepatoblastoma. So basically, if let's say we saw this kind of placenta, we need to inform the neonatologist or the pediatrician in charge. Probably has a detection prior to discharge lah. Okay. So this is how it looks like. In another section, you can see some grape-like lesion within the placental disc. So this is how it looks like under light microscopy. You can see it really looks like a it's a hydropic villi. It will strike you whether this is a hydatidiform mole. But be aware, it also always associated with these thick wall blood vessels. My first encounter with this case is with Sharina lah. That's my first encounter showing. She shared this case with us. Okay, the other thing is the umbilical cord ulceration. So basically what happened, there's there's loss of water jelly covering the vessels. So the vessels are exposed. So basically this condition, we sometimes need to inform the clinician. This child has concurrent intestinal atresia. Why the intestinal atresia? Because when the vessels are exposed, so sometimes these vessels undergo vasospasm. So this vasospasm can cause ischemia and eventually cause intestinal atresia during the development. The other thing is the second mechanism that cause myonecrosis. This lesion is probably the child has small bowel obstruction, so upper GI obstruction. So it allows. So upper GI obstruction followed by reflux. The child vomit the meconium. So when the meconium, basically it's reflux, and the meconium goes to the amniotic fluid. So the meconium in the amniotic fluid too is actually toxic, causing myonecrosis of the blood vessels. So the other mechanism is actually the child has abdominal epithelium between the umbilical cord and the intestinal atresia. Okay. So this is how myonecrosis looks like. So basically, there's degenerated muscles here, very pinkish, like rhabdoid-looking cells, pycnotic nuclei here. So this is how it looks like. Okay. Now we go to the microscopic findings of critical value. Okay. So first and foremost is the confirmation of the gross finding of that I mentioned before. Okay, and then this, I repeat again, the meconium-associated myonecrosis, because it's associated with neurocompromise or fetal surveillance, because not all meconium-associated myonecrosis will have the ulceration that I just showed you. I mean, umbilical cord ulceration that I showed you before. So probably it's just the child has been exposed to meconium for a long time. That's why they having this myonecrosis. The other differential of the similar morphology is autolytic myonecrosis secondary to intrauterine death. However, you can differentiate between these two, in which the IUD will be more generalized. I mean, if let's say you have the umbilical cord, I mean, what I want to say is not polarized. If polarized means if let's say for the part that been very that near to the periphery of the cords too, they're exposed near to the meconium too, it will be having that changes lah. Rather than kalau IUD ni, it will be the whole muscle too, it will be the circumferential too, it will be affected. I will show it with the picture later. All right, and also in autolytic myonecrosis, you will see meconium macrophages. Okay, just again the picture just now. So basically, this is the meconium-associated vascular myonecrosis. So basically, this is the outer side of the umbilical cord. So this is somehow the meconium is here. So only part, the one that really contact with the meconium will have these changes. Okay. Again, this is another example of meconium-associated vascular myonecrosis. You also accompany it together with the meconium-laden macrophages. Okay. Okay. This is. I just want to show you the IUD changes in IUD. You have this is one. I just want to show this is the lumen. So the changes will be the whole circumferential. It will be circumferential. It will have. It doesn't have the polarity. It means it doesn't have. I mean, the changes. I mean, towards the periphery of the umbilical cord, and also there's absence of meconium macrophages. Okay. Okay. Then the other thing is, if let's say you can see fetal malignancy involving the placenta. Usually it will be congenital leukemia. That's the commonest, followed by neuroblastoma. Still rare, but this is the I mean in order. I mean, the first will be commonest fetal malignancy will be leukemia, and then also followed by neuroblastoma, but it's quite rare. And the rarest, which is reported in literature, is malignant rhabdoid tumor, hepatoblastoma, undifferentiated sarcoma. Ini memang really there's no differentiation, which is very malignant, and the other thing is melanoma. Number 4, it will be the maternal malignancy, which is metastatic placenta. The commonest is melanoma. However, other tumors can also metastasize to the placenta, adenocarcinoma, or any other tumor lah. But Melanoma will be the commonest one. Okay. And the fifth one is intraplacental choriocarcinoma. I think it's quite straightforward. Intraplacental choriocarcinoma. And the other thing is inborn error of metabolism or lysosomal storage disease. This, there are certain findings in histology that you suspect this is an inborn error of metabolism. Whatever the it just tell you it is inborn error. What type of metabolites you have to convey to the clinician. They need to do some genetic, or they need to do some special tests for that. So what are the features of that strikes you that this child might have inborn error of metabolism? Usually I will see in these two cells, one in the Hofbauer cells here at the center part. The other cells is the syncytial trophoblast. It will have vacuolation. It will have either vacuolation, like here, this vacuolated Hofbauer cells and syncytial trophoblast, or it will have forminus Hofbauer of the Hofbauer cells, or it can have this fine granular cytoplasm. Or the most obvious one will be the vacuolation really strikes in the Hofbauer cells or in the syncytial trophoblast. Only these two cells, I will search for possible inborn error of metabolism. Okay, just maybe in the report, just there's speculation of within the syncytial trophoblast and Hofbauer cells, raising the possibility of inborn error of metabolism. Please investigate clinically, something like that. Okay. Okay, again, we'll repeat again, placental mesenchymal dysplasia, which is missed during grossing. Probably you have it just histologically, probably not so prominent as the very prominent grossly, but very you can see in the light microscopy. The other thing is some infections, specific infections that you might recognize, whether it's bacteria or torches. So like CMV, parvovirus. So we need to inform in your report and need to convey to the clinician. So I'm not going to deal this because it will be a whole lots of lecture on this. I will touch this just superficially. Okay, another thing is intravascular organism. So it's associated with maternal sepsis. So mom might need extra treatment, something like that. So this is sorry for the blurred picture. So I just want to show you this is acute veilitis. Acute veilitis usually is the cell inflammatory cells that involved would be primarily neutrophils. So what are the organisms associated with acute veilitis would be Streptococcus agalactiae, which is the GBS, and group B strep, and Listeria monocytogenes. Less common, you can see, we might see Mycobacterium, tuberculosis, Treponema, Klebsiella pneumonia, Haemophilus influenza, so this is Chlamydia trachomatis, and virus Coxsackie virus, B3 or Bacillus or other Bacillus species. So we know that it's actually associated with perinatal complication, preterm delivery, congenital infection will require long admission in NICU or PICU or IUD. So this is one to show you the intravascular GBS in septic abortion. So basically this is within stem villi. Then you can see all these bacterial colonies within the blood vessels. Then the last, I think the last one, probably the chronic histiocytic intervillositis. I think this is very important to recognize because it recur up to 100% in one paper. So it caused significant spontaneous abortion, IUGR, preterm delivery, and IUD. So if let's say the baby survive pun, it will have a prolonged PICU or NICU. We don't know whether the baby going to survive or not. So basically that's need to, have to inform the clinician because so that they can plan the next pregnancy, they will manage and intervene early. So not sure about in Malaysia, but for mother who has chronic intervillositis before, they will monitor the serum alpha fetoprotein and alkaline phosphatase. So when the mom has this elevated serum alpha fetoprotein or alkaline phosphatase, so they will know that current pregnancy also will be affected. So probably the mother will be be prepared. So this is the kind of the potential candidate for surrogacy lah, surrogate mother. The pregnancy will be by the surrogate mother lah instead of the mother itself. Okay. So just want to show our moderator punya paper juga. Okay, so this is a case report in Malaysia. A 41-year-old lady, 16-year history of 13 recurrent consecutive first trimester miscarriages. So it's just being missed. Yeah? So this mother has been pregnant 13 kali. Okay, it's just being missed that this mother has chronic histiocytic intervillositis. Okay, all right. So this is published in our journal pathology, Malaysian Journal of Pathology. Okay. So this is the histology of the, this is my own personal case. This is a 16 weeks for miscarriage. This is her second pregnancy, G2 para 0 lah, G2 para 0 plus 1. No, G2 para, 0 plus 2, sorry. So this is at 16 weeks. So basically, we see these histiocytes at the intervillar space. This is actually very mild, very patchy, but the other, it can be as severe as this as well, means very intense macrophage surrounding the villi. Okay. So it will be a spectrum. It can be patchy, small, but and also it can be very severely densely histiocyte infiltration only at the intervillar space. Okay. The other lesion I think need to be we need to know is villitis of unknown etiology. Morphologically, it will present like chronic villitis, meaning the villi are infiltrated by lymphocytes. Okay, so usually this is a diagnosis by exclusion. So after we exclude, selalunya we say please exclude torches lah. Basic first is torches. So if let's say there's no torches, everything. So for me, practically, kalau seeing a chronic villitis ni, I wouldn't straight away say as villitis of unknown etiology lah. I would just say chronic villitis. Please consider villitis of unknown etiology if all the etiology has been excluded. Bear in mind that if let's say villitis of any, there will be what you call high recurrence. Okay. But sometimes if you can actually differentiate between the infectious and the non-etiology ni, but I won't touch in this lecture lah. Nanti panjang sangat cerita. Okay, so the incidence is 5 to 15% of a third trimester placenta, and 29% actually causing, in IUGR baby, 29% actually you can see villitis of unknown etiology. and it's more common than the infectious velitis lah, infectious chronic velitis. Okay. Okay, again, just to highlight back again, its recurrent risk is 10 to 15%, as high as 40% lah. It associated with IUGR, SGA, intrauterine fetal death, neurological complication, usually the high-grade ones, okay, and neonatal death. If let's say the baby, the IUGR baby survive, being delivered, usually your baby too will have, in future when they grow up, they will have obesity, diabetes, hypertension, and coronary artery disease. So the problem with VUE ni, it's recur, and when it recur, it become worse. The next pregnancy, it become worse. So that's why sometimes we need to highlight. If we see this, we need to highlight this finding so that the obstetrician see, okay, the next pregnancy ni dia kena monitor lebih sikit. Maybe cannot very up to term sangat, just reach terms tu terpaksa beranakkan awal lah. Okay, and then they have to mentally prepare the mother that your baby has this problem, something like that. Okay. Okay, just superficially touch, what do we mean by low grade, high grade ni? Low grade ni means 2 or more foci. Should be 2 of lymphohistiocytic velitis ni. And then the focus ni is less than 10. Artinya 1 sampai 9 villi sahaja. High grade ni multiple foci, artinya more than tak kisahlah 2 dan ke atas, 2 ke atas, 2, 3, 4 dan 5, dan each of the focus tu mungkin 10, 11, 12 of villi. I will show you in the picture. So okay, the right side ni, this is actually basically a normal villi, but this villi dia memang ada chronic velitis. So saya this high grade because 1, 2 dia kena contiguous 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, more than 10 lah. So this already high grade, but not enough lagi because I have to be more, 2 and more lah to me. Sorry, kalau high grade ni 1 pun cukup, 1 and pun boleh. Tapi selalunya dia akan be more lah, jarang jumpa 1. Tapi if let's say the problem is when we see fragmented, and jumpa 1 ni sahaja. 1 sahaja fokus, yelah sebab hantar in fragment kan. 1 fokus of katalah 15 of this kata chronic intervillus ni of ni suspicious of high velitis of high grade lah, high grade punya ni. Then need correlate with the clinical. Maybe it's not, baby is not well, something like that. Okay. Okay, this is the higher power of chronic velitis. I think I have reached to the end of my presentation. So my reference this. Actually, this is, I think, good paper to read. So they just this paper only discuss the 3. The paper is quite lama juga, 2017. They discuss about VUE, maternal floor infarction, and massive perivenous fibrin deposition, and chronic intervillus histiocytic intervillusitis. So I think this paper will just give you an idea. Then with the current paper, we will have will be the the updates of these 3 lesions, and then the other textbook that you can refer. So these 3 among the 3, and also the AFIP lah, AFLP. So I like by the the one that sometimes I favorite is by Raymond Red Line. He will be this very practical how you approach placenta, and Drusilla J. Roberts ni will tell you what are the problem. Actually, if let's say you certain with the problems, if let's say you have fragmented, what are the diagnostic criteria? So somehow she will in this book they will, and also in the paper lah, how to diagnose. I mean, just how to give comments on that lesion. Okay. Okay, you can also, Drusilla has one YouTube channel. I mean, one YouTube on placental lesion. I think there's two talks on that, 2 placental lesion, 2 videos, and maybe you can just search on that. It's quite jelas lah. Okay, especially the vellitis of this one, vellitis of unknown etiology. Okay. With that, I think I reached the end of my presentation. So is there any question?
Thank you, Dr. Sally, for the chat. I think we have 15 minutes for the session. So hence I would like to invite anyone from participants and pathologists to ask questions or comments. You can on your microphone. Do, or what other examples of stains or immunostains that will perform in placental cases?
Sorry, Sharina, you are asking, is it?
Dr. Sally?
Oh, sorry. Are you asking the question? What are the? Sorry, the question again. Dr. Sharina, what is the question? Sorry.
Dr. Sharina.
Dr. Sally?
Putus.
Dr. Sally, can
Special
you
stain, is it?
maybe you can stop sharing for a while? So
Okay,
maybe
okay.
it helps with the connection as well.
Okay, fine.
Okay.
I already stopped sharing.
Dr. Sharina, maybe you can repeat the question again. Okay.
Dr. Sally?
Ya, saya.
I think I was disconnected a bit. Did you get my questions?
Oh, belum. Tak dengar, Sharina.
All
Saya
right.
dengar something stain, apa entah, tak ingat dah.
Okay. Do you routinely do, or what are the examples of stains or immunostains that you perform in placental cases?
Usually it depends on the case. Routinely, if let's say I will go by by the parts of the placenta, yeah. If let's say peripheral phalangitis, memang routinely doing PAS or GMS just to exclude peripheral phalangitis. Then tanya dengan ADMO ni, HVS, high vaginal swab ni ada candida tak? Then you have to correlate lah. And then for the extraplacental membrane, if let's say there's chorioamnionitis plus bacterial colonies, I will try to do like gram stain. If let's say it correlates with the high vaginal swab, so I just include in the report. We can say gram-positive cocci seen, correlating clinically with the GBS, something like that. Okay. Then if let's say placental disk also, kalau ada bacterial colony, obvious bacterial colony clumps tu, I will try to do gram stain lah. If not, chorioamnitis ke apa, I wouldn't do any what do you call apa tu PAS, GMS tak ada lah. And then if let's say going to villitis, chronic villitis, if let's say there's lymphocytic villitis, then I will do, sebab we on HKL can only ada CMV, so I will try to do CMV stent, especially kalau dia ada calcification. Absence of nucleomegaly, I mean the typical CMV nucleomegaly, but you have chronic lymphocytic villitis, plus ada calcification sikit, not because of retention, dia memang ada some tu, I will try lah do CMV just to exclude CMV placentitis. Buat saja, especially in fragmented kan, in katalah mak pun dia punya, suddenly I will see the history lah. If let's say the history is not so, mom is not that well, poor antenatal checkup, baby not well also, so I just do. So basically there's some answer to that, to the clinician lah. Otherwise there's no routinely, it's actually basically based on the findings. Whatever, what else? I think that's all lah. That's all I think, yeah. If let's say saya jumpa nucleated RBC, because I know you, Sharina, dah ada parvovirus. Kalau ada tu, I will send to you lah.
Okay, Dr. Sally, I think we
Yes.
have, I think there are more questions in the message panel. So I'll start with the first one. There are questions on what is the cause of chronic histiocytic intervalocytis?
The cause here. The cause to chronic intervalocytis here, basically there are a few pendapat lah, I mean a few ni, but usually because of maternal what do you call maternal macam dia macam graft versus host disease. I mean mom against the fetal and maternal punya antigen. So that's why that's the most the other thing is infection. But sometimes because they said, if let's say you can not a good suggestion lah, if let's say probably change of partner may improve the chronic apa tu intervalocytis and neck pregnancy sometimes. I mean that's the other apa tu lah. So kadang-kadang for parents who have this I mean problem ni, kadang-kadang we I know there's certain apa tu maternal fetal specialist ni, they will give some medication. I'm not sure what is it. I think Sharina memang aware. I mean dia ni. The other thing is, lagi satu, they will offer surrogate. That's why in obviously they will offer this surrogate ni, ataupun that's how I understand it. Ada
Right.
lagi yang Sharina nak tambah ke?
I think we need to proceed with the second question. Is that okay, Dr. Sally?
Oh, more than 25% perilous fibrillation and suspicious. This 25% ni should be, Dr. Ng, should be gross. Gross apa tu, gross finding. Dia macam so I assume ni term ke apa ya? To me yang 20
the question asks you what was your suggestion on comment to put on the report if we see this 25% of perilous fibrin?
I would just say, there's increased perilous fibrin deposition, unable to exclude massive, if let's say kita dapat fragmented lah kan, unable to exclude massive perilous fibrin deposition, full stop. Please monitor next subsequent pregnancy, as this can has a high recurrent risk, something like that, macam tu lah. Because we cannot be very sure ni, banyak caveat dia, especially kalau yang first trimester punya ni, you must not have that, kita tak ada, it's not a retained retain miss abortion sebab dia pun can cause massive perivalous deposition, and also dia bukan yang being induced. I mean, you bagi prostin to abort the baby pun will have that kind of findings juga in early pregnancy. So if let's say the history tak ada macam tu, we just very vague sahajalah. I would just say suspicious and suspicious of massive perivalous fibrin deposition ataupun unable to exclude massive perivalous fibrin deposition, something like that. Please monitor. Monitor the subsequent pregnancy lah for IUGR or something like that. I hope that will answer your question, Dr. Ng.
Okay, still on the topic on prevalence fibrin, there's a question how to differentiate prevalence fibrin deposition versus infarcted villi.
Okay. Susah juga. Selalunya yang for me to diagnose the diffuse perivalous fibrin deposition ni should be dia mesti dengan the gross finding. The gross finding. Dia banyak I understand if let's say kata kita dapat tu mungkin dia sampel at the tepi, at the edge kan, at the edge of placenta. So edge of placenta memang tend to have increased, there will be some degenerated villi and surrounded by fibrin. So I will senyap sahaja lah. I wouldn't say. Lagi satu lagi infarcted villi ni dia kadang-kadang ada neutrophils surrounding the villi tu. I also see I banyak certain criteria kena tengok lah. Dia punya history macam mana kalau infarcted villi ni. Kan? First saya kena tengok. First, sama ada this is intact placenta or fragmented. Kalau fragmented tu, anything under the sun you can comment lah. Tapi katalah this is a full intact placenta ya. Then you can know already whether this is at the maternal floor ke at the side. That's how a full examination of the placenta really bagi you confident to diagnose this massive perivalous fibrin deposition. Kalau in pieces tu really saya rasa you letak apa-apa pun boleh sebab based on the suboptimal placenta, it can be like this, it can be like that, however begini. So banyak, too many caveat you want to put there. Kan? So sometimes I just ask the clinician. Tapi kalau telah history tu, katalah in fragmented tu, this is the very bad obstetric, katalah di pregnancy yang ke-6, tak pernah ada anak kan. You then bagi tahulah the clinician to highly suspicious of massive perivalous fibrin deposition. Something like that lah. Saya kadang-kadang tengok history tu juga. Where you want to push your punya diagnosis tu macam mana, especially in this fragmented lesion lah. That's I hope that saya jawab that soalan.
Okay, we have 2 more questions. Is that okay?
Oh, boleh. Tapi the tuan rumah lah, macam mana?
I think okay, good.
Okay.
There's a question on the differences between chronic villitis and diffuse chronic proliferative villitis. What are the differences?
Chronic villitis and
diffuse chronic proliferative villitis.
Diffuse chronic proliferative villitis. Saya tak pernah dengar that term, chronic proliferative.
Again, this is part of the syphilitic placenta, probably, I think. I'm not sure. The questions.
The proliferative tu saya tak berapa ni. Tapi tak apa, you can email ke saya ke, nanti saya cuba ni. I actually cannot understand that proliferative villitis tu. Not
okay, all right, it's okay. There's another question from Dr. Zarka here. How to differentiate mesenchymal hyperplasia, I think dysplasia probably, with hydropic villi?
Okay, that mesenchymal dysplasia tu dia the absence of that polar, what do you call that, trophoblastic hyperplasia yang circumferential tu. Lagi satu, dia ada that thick blood vessels. Thick blood, very thick. Sekejap, kalau saya boleh share balik saya punya, tak payah share lah. Boleh share ke? Thick blood vessels in that villi tu. In that villi, they have you tengok tu, kenapa dia ada very thick blood vessels in that hydropic villi. Usually in apa tu, hydrotidiform ke atau hydropic villi ke, you don't have that ni. That's why dipanggil dia mesenchymal dysplasia. Okay, hope it will answer question.
Okay. Probably, what is your usual turnaround time in reporting placental cases in your center? Are they treated the same?
Okay, for now ni saya memang pilih kasih lah. I will have to what do you call, it should be sebenarnya kalau ada yang by urgent tu, kalau so far ni belum ada yang urgent lah. Okay. Because saya bias, I have to case dulu then baca the placenta. So basically saya rasa dalam masa sebulan it would be quite hard. In certain center, like I understand in UKM, they want it macam Prof apa tu, dia nak cepat ya, especially chorioamnionitis, because the neonatologist want it whether this chorioamnitis or not, because they want to treat the baby as soon as possible. Sometimes because the baby they present sepsis subclinically, they ada sepsis but subclinically the baby, the vital signs are okay, something like that, but actually they are having sepsis. So with the report of chorioamnitis, so they will just treat the baby needs. So actually how aggressive your neonatologist. Basically placenta ni dia mesti hand in hand with the neonatologist, because yang I understand juga, because the report of the mother, the report will be under the mother's punya ni, and then the baby belum ada its own ni. Then the initial management it will be susah sikit lah coach, because the report will go to the mother and the baby will have its own atau baby off, something like that. So sometimes the follow through tu, kalau the system is not THIS ke apa, it will be very difficult. That's how I understand lah. I mean the difficulty that of that placenta. Tapi basically I think 1 month is okay, but depends on the neonatologist how aggressive they want the report. Then you have to apa tu, ni dia lah, layan dia.
Okay, Dr. Sally, there's one a question I think Dr. Moha would like to ask.
Yes, Moha. Di hospital
Assalamualaikum
gitu.
Sally.
Waalaikumsalam.
Welcome back to Sabah. Okay, Sally, thank you very much. Very nice talk. Boleh tanya dalam bahasa Melayu kan? Senang.
Boleh, senang.
Bahasa Sabah lah, biar orang lain tak faham. Okay, Sally, I nak tanya, what is your stand against sending small biopsy, bukan biopsy lah, small placental tissue, you know? Kadang-kadang dia orang ni macam not really want to know diagnosis, just hantar aja, suka hati dia aja hantar. Terutama kalau you dapat, especially kalau in Sabah ni biasanya from district hospital where patient datang dengan IUD kan, tiba-tiba IUD and then MO tak tahu pun what is the cause of IUD, and then dia orang just follow, saya tak tahulah guideline daripada mana, just ambil sikit je dekat hujung je placenta and then hantar kat kita. I think it's a waste lah, because it's a waste of in term of resource, our resource kan. Tapi I don't know how to educate them not to send, let's say if you don't have. So let's say if you don't give a complete history and then you don't give us, you know, complete placenta, how the placenta look like grossly, you know, what you see there, and then macam mana saya nak buat diagnosis. So apa-apa yang saya buat diagnosis is mature chronic villi, no fungus, no granuloma, no inflammations, and then last no significant pathology. Itulah apa yang saya boleh buat.
Ya, betul.
Itu
No significant, I mean, saya kata there's no significant pathology in the suboptimal placenta, something like that.
yes, macam tu. So saya rasa macam mana kita nak educate them for you lah.
I
Saya
think kalau untuk semua hospital ni, if let's say kalau nak suruh hantar placenta, memang especially kalau baby factory memang tak boleh lah, tak boleh ni. So first thing first kan, kita kena cakap dengan kita punya colleague tu, the ONG tu. First, dia nak hantar placenta tu kes mana dulu? Mungkin kita cakap dengan dia. Mungkin okay, apa kata we hantar yang IUGF nya kes sahaja dulu.
yes.
Ataupun kita pilihlah IUGF nya kes sahaja dulu. Ataupun kita hantar yang IUD. Tapi I will tell you, IUD pun I memang tak boleh cope. Sebab katalah you punya IUD is very high in your hospital. You memang macam
yes.
you duduk lah.
I think mungkin kalau let's say IUD pun, kalau first time IUD, I don't think is what we call it, is significant for you to send. Maybe recurrent IUD or recurrent previous history of recurrent apa nama dia, recurrent abortions tu boleh lah hantar. Kalau just sekali and then you hantar sikit, and then I think it's a waste lah, a waste of resources, I rasa kan. Tapi it's difficult to we call it, to educate them, betul tak? Mungkin tunggu NG balik lah kot ya, biar NG educate those tabahan.
Tak, the other thing is lagi satu, you empower the staff nurse. Actually saya nak macam basically in our report tu, katalah dia hantar kita sikit pun, empower diorang kena measure, diorang kena tahu measure the cord tu macam mana, measure the cord, lepas tu berapa coil dia kena trim the placenta tu. Actually at least dalam report tu based on ni, placenta is small for gestation. Maybe placenta, kadang-kadang baby tu normal besarnya tapi placenta tu small, you understand? So mungkin kadang just by the weight, it's just mungkin is insufficient. Baby placenta tak boleh nak tampung that baby. So the answer is already there. It's actually the placenta cannot tampung the ni. That's probably the reason of IUD kan. Just based on the size of placenta, the weight lah basically, and then the punya thickness, dia punya hanya measuring sahaja. Basically trim lah. Nanti kalau yang I understand, sebab yang kadang-kadang sampling pun banyak orang tak nak juga. Sebab itu pun kena minta apa tu? Patient punya what do you call,
kan?
Yes, apa tu, kebenaran. Because saya pun ada problem juga kat sini, sebab ada tu dia nak minta cepat, dia nak ke bumi juga. Dia tak mau di satu hari. So tak fix pun, buat apa yang ada, then boleh jugalah, at least ada finding. It's just the placenta tu very small, and then dia ada multiple infarct, and also dia ada villitis. So alhamdulillah sempat boleh tengok lah, walaupun dia ni, it's just I really understand this will be the major issue lah sebenarnya. Tu memang I think maybe start small in the hospital. That's why at first I think kita cakap dengan ni, with the clinician, what case do you want to set the case, apa yang betul-betul you nak tengok. Memang there are a few, kalau kita tengok guideline, there will be a list of condition that you, maternal diabetes lah, maternal hypertension, IUD, unexplained, there will be a lot. So you just choose apa you the clinician nak. Mungkin dia kata, okay, I want to see IUGF punya cases. Can I explain this? Supaya the next patient tu, supaya they actually go back to the clinician juga, so that the next pregnancy tu, that clinician tu boleh manage. Betul tak? So that's kita kena bagi ada satu ni. Memang kita tak boleh cover because we are not in the ideal setting. I think to me, we have to discuss with the clinician, I mean the ONG side. Of
Yes.
all ni, mana you rasa yang you hantar whole placenta that they can manage. Kalau dorang dapat the information tak boleh ni, yalah, non significant pathology memang.
Yes. Itulah punya diagnosis. My favorite diagnosis for placenta.
Yalah, memang semua genetik dia sangat cepat. Saya
Yes.
memang agak lambat lah, because saya kena clear check semua ni lah, sebab kadang-kadang saya tak faham apa MO tu cerita kan. Then you have to quantify. Actually the gross placenta ni should be pathologists lah, because they need to see the lesion, how much it affect the volume of the placenta, because the lesion to affect the lesion that occupies the placenta tu, it will reduce the placental reserve. So how good is the placenta pun, kalau ada banyak lesion, it will affect already their function. So basically itu semua in the comment lah.
Yeah. Itu kalau itu very lucky lah kalau we dapat the whole placenta. Tapi basically kita tak, saya rasa saya tak pernah ke dapat the whole placenta sini. For me, saya tak pernah dapat the whole placenta. Maybe other pathologists di Sabah pernah dapat lah. For me, saya tak pernah dapat. Yang saya cross sendirilah, what I mean that.
Because you are really being with our culture kan, we are really not that fortunate to ni. Tapi whatever it is, for the for investigation for perinatal autopsy lah basically, ataupun satu juga. Sometimes you can get away from autopsy by the placenta. The placenta. So just kerana you compromise lah, you want autopsy kan, hantar placenta. Something like that lah.
Okay, thank you.
Okay.
Okay, thank you, Dr. Moha and Dr. Sally, for the Q&A sessions. So I think I'm afraid that there's already 12 minutes past 11, so I think we need to have to end these Q&A sessions. Any remaining questions, you may direct to her personally, if that's okay with Dr. Sally. Before I close this session, I think Dr. Zara would like to share something.
Yes, this is announcement of the upcoming. Sekejap ya. Is my setting speaker or viewer?
Speaker.
Ni? Speaker ke viewer?
Viewer.
Okay. So, next month punya presentation will be by Dr. Navarasi. She'll be talking about endocrine pathology. So, I hope the participant will really religiously, I would say, come and participate. Same time, on the 19th of March. I know that weekend going to be a bit busy for some of us, especially with families, but I hope boleh join lah. And one more thing, please check your chat box. There's a link to the feedback. Please send in your feedback so we can after that issue you your certificate. I will be putting it in also inside the WhatsApp group as well. Okay. Back to you, Dr. Sharina, to close and wrap up this session. Thank you.
Okay. Certificate of participation will be emailed after we receive the field feedback form. Okay, so the session is recorded, so the recording will be available for paid participants after the talk. And thank you everyone for joining this session. I'm sure we've gained some knowledge from Dr. Sally topics presented today. So finally, thank you again to Dr. Sally for her time this morning. Again, kindly all participants fill up the attendance form provided, and to all, do have an enjoyable lunch and your weekend ahead. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much. Assalamualaikum.
Waalaikumsalam. Terima kasih banyak-banyak. Happy birthday, Dr. Sally.
Thank you, thank you.
Happy birthday Sally.
Thank you.
Bila birthday Kak Sally? Hari ni ke?
You hari ni.
Oh, happy birthday. I was thinking, dah lepas ke? Belum lepas ke? I was like, wah. So this is your present lah. Instead of
Memang.
us giving present.
Tak boleh tidur dia buatnya. Okay, thanks for the wishes everybody. Assalamualaikum semua.
Pandai Zara dera Sally on her birthday
Okay.
Happy birthday Dr Sally.
Terima kasih
Apa,
Dr. Yatiza.
Nanti ramai-ramai kat sini
Semoga
doakan.
sentiasa dalam rahmat dan barakah Allah.
Amin, thank you.
Selamat ulang tahun.
Amboi.
Ulang tahun.
Selamat
Selamat
ulang
ulang
tahun.
tahun.
Happy
Birthday
birthday
to you.
Okay. Alright.
Okay, thank you very much. Assalamualaikum.
Waalaikumsalam Dr. Yatiza. Assalamualaikum semua. Zara, saya leave ya ni.
Boleh.
Okay, bye-bye.
Bye. Saya tutup untuk semua orang ni. Saya nak stop
Alright.
recording.